Good morning, everyone. First of all, apologies for being just a little bit late. Technology is amazing and torturous all at the same time. So thank you for your patience. I am super excited to get to introduce Laura Rathbone, who will be our first speaker for today. And what we're going to start with is, Laura, can you show us something that's special to you in your home? And tell us a little bit about it.
So this is a bag of coffee beans, and these beans were roasted by my lovely husband who works for this brand. And this is really important to me because basically I don't function without it, and it's the thing that keeps me tweeting at 1 o'clock in the morning. Probably me and the president, who probably should all both shut up, but this is the thing that keeps me going. And so this is really important on a pragmatic level, but also on an ideological level, because this is a fair and sustainable coffee brand, and they're trying to make a difference in their profession and their brand. So it's very important to me, and I like to support what he does as well. So
That was a wonderful commercial for your husband's coffee roastery. Awesome. And it is delicious. I had the opportunity to go and have some when I was in Amsterdam. Was it just a year ago?
It feels like 10 years ago, doesn't it, though? The
It
world
really
has changed so
does. Okay, well now, just so that we don't torture Laura out anymore with the wait regarding her talk, I'm going to read just a little bit about her before we start with the presentation. So Laura is a clinical specialist physiotherapist working in the field of persistent and complex pain, and lives in Amsterdam, the Netherlands. She is the host of the podcast Philosophers Chatting with Clinicians, which brings and is working on understanding the model of embodied cognition and how pain might fit within this. She co-hosts Le Pub Scientifique in Amsterdam, which is amazing, and guest lectures on the topic of pain and incorporating psychological frameworks into practice. So, without further ado, barring any technical difficulties, we're going to hear Laura's wonderful presentation now.
Hello, welcome to my home. So when I was thinking about how do I bring this topic of psychological flexibility across into a virtual recorded experience, really had to go through some process myself, and really take a step back and think, well, what is it that I want to achieve with this talk? What do I want to do? And I was really challenged myself. Usually when I'm in a real time, sort of not necessarily face to face, but even real time face to face or virtual experience, what we're creating is this sort of shared space of meaning and exploration. And there was a real part of me that was driven towards comfort seeking, safety seeking in a recorded session. And you almost got 50 PowerPoint slides of all the evidence behind, social behavior and communication strategy, and what evidence do we have that therapists are othering, or and a whole sort of pre-practiced and typed up presentation. And I imagine that there are some of you out there who would really like me to have done that. So I acknowledge you and hear you. But that would have been me modeling a kind of inflexible response. It would be me feeling uncomfortable, unsure as to whether I can bring this information across in my usual way, or in a way that makes the most sense for me, and the way I think it makes most sense to other people. And so I would move into what I think are the norms and expectations for when somebody is delivering a talk. And I imagine those norms to be that I would have a PowerPoint slide presentation, and there might be some funny videos in there to make you laugh or make you think about it. And there's probably going to be some sort of infographic to demonstrate how we communicate and how we develop our own network of meaning and behavior and responses to our environment, and how we then share that interpersonally between each other, and how my action will be sent across to you and you will respond to that based on your meanings. But instead, I chose an uncomfortable place, which is to try and bring across an experiential type of learning, a sort of self-reflexive moment to learn about how this is for me and how this is for you in a recorded way. And this is what I've come up with. And we're thinking about this idea of psychological flexibility, which is out there. It's something I teach on to clinicians. It's something that we're moving into as a sort of as we move more into these acceptance-based approaches and models for supporting people with an experience of pain. And I often find myself asking the question, well, what does this mean for us? What about us? Are we doing this work? So if you got my message on Twitter, I invited you to get a bucket of cold water and some ice, which I've got, just to prove it. And add your ice to the water. And I'm going to invite you to put your hand in, or your arm, or your foot, depending on what works for you. But just before we do this, I do want to say, like, there is no expectation on you to do anything that you don't feel comfortable doing or you don't want to do. If this just doesn't feel like it's the right thing for you and your body and where you are right now in your journey, like, please make a choice that works for you. I have no expectations on what your experience is. I've got no way of even knowing what your experience of this is. With all that in mind, I'm going to invite you to put your hand in your bucket. Okay. And I want you to notice what that feels like. Have a moment where you recognize or acknowledge or spend some time observing the sensation of it. Perhaps noticing when mild discomfort starts to become quite unpleasant. And noticing if there's any changes in your breath rate, your heart rate, if you're starting to see changes in your thought patterns, if the thought to remove your hand or the urge to remove your hand starts to come up. Just noticing what's happening there. How your sense of self is responding to this change in the environment, this unexpected, in some ways, environment. Very different experience from what you had previously been experiencing in this part of your body. And perhaps even noticing what this unpleasantness might mean to you, what it might be driving you to do. And of course, you can remove your hand when you feel that that's right for you, when you feel you've reached what you can tolerate. Take a moment just to notice in your body. Now you've removed your hand, how does it feel? what's left over, what's the residue of that experience. Maybe even just noticing if you've done something like that, this sort of movement that I've just done, I've sort of wanted almost to test out, am I still okay? Is everything still functioning? Can I keep the blood moving? These actions, these movements towards somehow finding safety in this potentially unsafe experience. Maybe noticing if you were tempted to, I don't know, somehow fight with your experience of unpleasantness. Fight with it in order to stay with it. Maybe you were trying to stay with the activity, the action. Maybe there was some motivation that was bringing up this urge to fight with it. Or maybe there was a sort of action of trying to ignore it, trying to somehow not have the feeling of unpleasantness. Maybe you wanted to pull it out quickly. Maybe you did. Maybe it got to the point where you just had to, nope, not doing that anymore. Remove your hand. Maybe you chose not to do it at all. And maybe there was some other action or response that you observed within yourself that maybe I haven't been able to come up with. The point of this experiment was not to say that one way of behaving is right or one is wrong. It's more to highlight that when we feel profoundly uncomfortable, we may start to behave or react to that discomfort. And I use this exercise quite a lot with clinicians and students to sort of give them the experience of being profoundly uncomfortable, maybe even pain, so that they can understand that when you're in pain and when you're having that experience, there are the urge to get away from it can be overwhelming. The urge for it to stop, the desperation for this experience to be over can be overwhelming. And it's a moment and a way for people who may have never really experienced much pain in their life, particularly not a pain that persists or lasts for a long time, to have an empathy or a moment of empathy with people who are experiencing persistent pain that might feel this way. They might feel desperate for their pain to end. And for us to have a moment where we realize that inviting people to move across to an acceptance model or a resilience-based model is not a small thing. It's a hugely difficult and emotionally taxing and scary process that for some people may need a lot of time and for other people may need less time. But that for us as a clinician to somehow tell another person how to do that or have an expectation on how long it's going to take them might be an act of non-compassion. And often what happens is there is this moment where our new generation of clinicians or clinicians that are transitioning into working more focused with pain, take a moment to step back and slow down and give more space to the other person and take their time. But it's also doing something else, and that's what I want to talk about here today. It's also providing a moment for us to just reflect a little bit on what we do in that situation. What does it feel like for us to be uncomfortable? It gives us a safe space as clinicians to, for a moment, center our experience of working within the field of pain and with people who are experiencing pain that is sometimes heartbreaking as a human to see and to witness, to bear witness to observe, and to feel the responsibility of perhaps wanting to fix it or take it away or solve it. So can we use this as an opportunity to reflect on ourselves, on the who we are, the history of us that has come with us into the clinic room as we sit opposite somebody else experiencing their pain, and try to get a sense as to what are our behaviours and coping strategies and mechanisms for managing and coping with difficult situations. So I'm going to invite you to put your hand back in. Perhaps it's an opportunity to notice how you're feeling right now about having to go back in. Going back into an uncomfortable situation. How flexible are you feeling? How open to that are you feeling? How emotionally resilient, if that's a construct you're aware of. Just to reflect a little bit, I'm already feeling that I don't want to do this. So I've had my hand in and out of this bucket quite a bit today, practicing, and I have some awareness of the discomfort that might be coming. Have some awareness of what might be expected of me. Have some rules that I may have already put in place on myself as well that might mean I need to be in there for a long time. Or I might feel that is an urge that I need to satisfy. So for me right now, I already have a little bit of reluctance. I'm already experiencing this discomfort of not wanting to turn towards and sort of wanting to procrastinate, which is what I'm doing beautifully right here. But okay, so let's go back in. And again, just notice what's happening in your body, what's happening in yourself. How uncomfortable are you feeling? Are you experiencing the same coping strategy? Are you wanting to pull out? Are you wanting to move towards? Are you using a resilience tactic like awareness, breathing, relaxation? And at that point where the discomfort starts to tip the point, it's the tipping point, where you've gone from thinking, yes, I can tolerate this, to, no, I can't tolerate this anymore. What's that feeling? And of course, the pulling out, which you're welcome to do so, is that, oh, thank goodness I can come back to my comfort zone. I can come back to a comfortable place, which is outside of the cold water. Just taking a moment to remember that that might not be an option for many of the people that choose to work with us in the management and navigating of their pain. But what is that comfort zone that we're coming back to? So, of course, the cold water and into the room temperature. The room temperature is our comfort zone. This is where we feel more harmonious. This is this return to a place of safety. And that makes a lot of sense. And it works for me, works for my interaction with the bucket. But what would be our place of safety as clinicians that might be trained in the management and treatment, maybe, of pain? And I think some of that comes down to how have we been educated? What have we been trained? What model have we been trained in? So speaking to my own experience, that comfort zone, certainly when I first graduated and wasn't exposed to the concept of pain as anything else other than what I had been taught in my undergraduate, that comfort zone might be my assessment process as a physiotherapist. It might be the model that if I can just find the tissue that is responsible for this person's pain, then I can in some way modify that tissue or the way that tissue behaves in that person's body, and that will somehow help this person's pain. If I can find the weakness, then maybe I can strengthen it. If I can find the restriction, then maybe I can change that. If I can find the maladaptive movement pattern, then maybe I can retrain it. And the theme of that seems to be that I am somehow going to take away this pain. I am going to have the expert knowledge and accumulate enough knowledge that I can somehow take that pain away, fix it, cure it, be the hero, maybe. And when I am in environments and clinical encounters that put me outside of that role, that safety, that ability to use that model, then where am I? Am I part of the problem? Which would be deeply uncomfortable for somebody like me, or for me, because I can only really speak to my own experience on this. It would be deeply uncomfortable for me because the motivation to go into healthcare is all intertwined with this value of wanting to help people, wanting to, not wanting to hurt people, whatever is the opposite of that. So I might be in a situation where I can't make sense of this person's experience of pain based on my traditional model, or it doesn't quite fit with what I would expect. And so there's a kind of dissonance happening between my expected norms, what I have been taught, my knowledge, my beliefs, and what is showing up in real time. And so I might not know what is another way of doing things. But I might cling very tightly to my model of practice and my conceptualization practice. Or I might, in some way, reject the unpredictability or the dissonance producing experience. I might reject that. And those things may lead me to behave in certain ways that are not necessarily helpful for the person who is experiencing pain and trying to access care. So what I'm interested in here is how do our coping strategies as people and clinicians to that dissonance, to that discomfort, show up in our decision making, clinical decision making, and our communication within this alliance, this therapeutic alliance. And what is the impact of that on the people accessing our care? And I think we might need to come back a little bit and start trying to reflect on how we conceptualize ourselves and our role within this environment. Where do we place ourselves? Even though sometimes that might feel uncomfortable, the acknowledgement and allowing of this idea that we might conceptualize ourselves as the hero of this story, because that's what we've been trained in, although it might not have been explicitly said to us, and we might never speak this out loud. But these more traditional biomedical models, approaches to managing pain from a physical health perspective, might implicitly be saying to clinicians, you are the fixer, you are the one with the right knowledge to fix this person's pain. And when that's challenged, just how comfortable do we feel? And we have a word for this discomfort that comes up, and we call it dissonance, and I've said it a few times already. But when somebody is experiencing dissonance, what we're saying is that they feel discomfort, they feel out of step, out of harmony. There is a challenge to their knowledge, to their beliefs, to their norms, that is providing this experience of discomfort. And when this discomfort comes up, we are driven, motivated to reduce that discomfort so that we can feel more comfortable. And in some ways, that's what we're doing with the ice bucket. We're creating a kind of physical dissonance and noticing that powerful urge to return to a comfortable place. And in this talk, I want to explore what dissonance might look like in the therapeutic encounter, and why that might be something we should be thinking about and focusing on as clinicians interested and committed and motivated to helping people with their pain. So what might that look like? Well, it might be that we find ourselves trying to clinically diagnose the cause of pain. So we might be using lots and lots of clinical tests or scans to try and in some way either put our minds at ease that there's nothing serious happening, or find some pathoanatomical, some anatomical abnormality that we can place pain onto, so we can somehow make sense of this through a comfortable, established model of anatomy. It might be that we cycle through lots of approaches to symptom modification. If you're a physiotherapist, that might mean, or a massage therapist, or someone that is using touch-based therapy, that might mean that you're using lots and lots of approaches like different manual therapies, different needle-based therapies. You might be using different exercise strategies, motor control, motor relearning strategies. It might be that we're trying to just give the right education or lifestyle advice, and we might tell people how to start living their life or how to understand their pain. We might be cycling through trying to find the right metaphor, in some way hoping that this changes the pain of that person in front of us. And I'm not necessarily saying those things are wrong. What I'm advocating for is a moment of self-reflection where we notice that that's our behavioural response to hearing the story of pain and witnessing, this bearing witness of somebody else's distress. It might be that we start labeling this person as not fit for physio, not fit for our treatment, and referring them on to somewhere else. It might mean that we try to push that away. Not my job. That's something else. When the symptom or the person doesn't respond in the way we would expect them to, or the way we have maybe been led to think or believe that they should respond. And that when that sits outside of our expected norm, our behaviour to reject that might be present. And so again, I keep coming back to this idea of, well, what are our coping strategies? What are we doing? And in that way, is something like the model of ACT, the model of psychological flexibility, the sort of process-based model, is that actually something we could start embodying and using for ourselves? Not to center ourselves in somebody else's story of pain, but so that in some way we're aware of ourselves when we go into that therapeutic environment, into that encounter, into that relationship. And that awareness somehow allows for this space for us to maybe step back and give room to the other person, behave differently, act differently. Because this concept of psychological flexibility, we're not saying that one behavior is right and one behavior is wrong. It's the process of connecting to what's showing up for you in the present moment and allowing for a choice point to choose a behavior that perhaps sits more in line with your values or in line with your goal, your idea for yourself and how you want to respond in these situations. And it may well be that the way you normally respond is completely appropriate and that that's the way that you choose to continue. But it may be that that little bit of space, that little bit of wriggle room, allows for a different response that may still feel uncomfortable, but that may be more workable or more helpful in the moment, in that intersubjective moment between you and the person that has chosen to work with you and collaborate with you on their experience of pain. And it might allow more space for that. Because an inflexible response, so an unwillingness to experience that discomfort, might start to bring around some of the actions and some of the strategies that actually our pain ambassadors and patient advocates with a lived experience of pain are telling us they're experiencing in our clinics regularly. This story, this experience of not being listened to, feeling like they haven't been heard, like they haven't really been asked what it's like to be them. Like the clinician hasn't really looked up from their standardized assessment protocol to see the human that is suffering, to empathize and validate and acknowledge that they might not have the answer there and then, and that they might have to open this up into a shared space. The idea that maybe they haven't been believed, that the clinician may feel so uncomfortable that actually elements of gaslighting might start to creep in to how the clinician communicates with the person in pain. They might start saying things like, are you really in a 10 out of 10 pain? You don't look like you're in a 10 out of 10 pain. Or, you're very stressed, aren't you? You're very anxious. Does that affect your pain? And of course, we know that these things may have an influence on people's pain. But what we don't want to suggest is that they in some way are the person's pain. That we don't want to necessarily skew the story, skew the experience to say that what you're saying you experience might not actually be what you're experiencing. Because I think that's what we're hearing people tell us is happening in our clinics. And I wonder whether in our desperation to get better at treating pain, because we're desperately trying to lower that discomfort of not knowing how to treat pain, or of wanting to solve somebody else's distress. In our desperation to make that experience stop, that discomfort stop, by finding the right treatment or the right education, the right words, the right metaphor, the right science to explain it, even when what we're seeing in our evidence is that there so far there is no right way to do that. In our desperation to accumulate these treatment strategies and approaches, what we've actually done is we've forgotten a huge process that might need to happen. And that is, sitting with our sitting with the discomfort of reconceptualizing our role in somebody's journey with pain. Taking the time to really go through that process of recognizing that we may have entered into healthcare to make people better, to stop this ill health, whatever that is, and to reconceptualize that our job might be, in many, many ways, to facilitate a safe and shared environment for the person to fully experience and explore what their symptom might mean to them. So that in many of our clinics, that symptom will be pain, but not necessarily limited to pain, if we really know what that is. But maybe we need to go through this reconceptualization of our role as the treater into this sort of more supporting role, this standing alongside role, this collaborative role, this equal role. And we can only really do that if we give space, if we come down from this hierarchy of this sort of protection, this armor of, well, we're the expert, we know. If we let that armor just chip away a little bit and rehumanize ourselves as people and clinicians, reanimate ourselves, allow our vulnerability in, then we're sort of holding up our end of the bargain. We're holding up our end of the deal of this therapeutic relationship. We're saying, yes, I'm going to hold part of this, and you're holding part of this, and we're going to hold this together and work this together. And that might need us to slow down, and that might feel quite uncomfortable. So I'm going to invite you to put your hand back in your bucket, because that's what we do when we do this work. We go back into the bucket, we go back into an uncomfortable situation, and we notice, okay, now I'm bringing in with me some of the discomfort that I've been carrying around from the last time I put my hand in the bucket. And actually, there is already an influence on my next action, and that I can just be aware of that and acknowledge that and reconnect and commit to my values and my goal as a person that is a clinician that works with a particular experience like pain. So in this situation, I'm acknowledging that I'm bringing with me some of the stuff that I've already been through as a person into this next experience. And by acknowledging it, I'm giving it room. And by giving it room, I'm allowing for space for this flexible response. Well, I can fight against it. I can go in there and prove to you all at home that I can do this. I can keep going into this discomfort. Or I can acknowledge that I'm starting to feel a little bit fatigued by this constant discomfort. Maybe I need to start thinking about my boundaries and what's right for me, so that I can keep showing up and keep giving my all and keep being flexible without having to revert back to my comfort zone when that might be unhelpful. So in this way, I can make this choice. I can regulate myself. I can figure out what's going on within me so that I can fully experience this maybe this unpredictable situation, because I did not expect to find that funny going in there. So maybe I can open myself up again to this, open myself up flexibly again to this experience, knowing that I may have already set some rules and norms or had some experiences that might in some way create an inflexibility. And just notice what it's like to be uncomfortable. and that need to come back to a comfort zone, and reminding myself that my comfort zone might not be comfortable for the person that has chosen to work with me for their pain. My comfort zone might actually just be making me more comfortable and not necessarily helping the person in pain, which is ultimately our job. We're therapists. Our job is to support and create and facilitate therapeutic environments. It's not necessarily what we do all day, every day, but when we're showing up to the clinic, can we show up? Are we able to show up in a flexible and open way? And so in this way, this ice bucket, it is a metaphor for the sort of the emotional labor of noticing your own discomfort and your own choices to act within that discomfort, as opposed to simply reacting and returning to comfort, which may not be a comfortable place for the people that you are committed to and motivated to supporting. So I guess what I'm saying here, what I'm interested to share with you, is this question: just how psychologically flexible are we? And are we noticing how our inflexible responses and reactions to perhaps some of our own dissonance is showing up in our clinic, and what the impact might be on the people accessing our space? And can awareness of that actually help us to do our job, help us to be the clinicians that we want to be, but perhaps in a reconceptualized way? So I welcome your questions, and hope that this has been stimulating, that it's brought a few seeds or thoughts around where we are as individuals and clinicians trying to do our jobs, and perhaps provided a safe space for you to explore your own behaviour and your own coping strategies of working within this this area with the people who we work with. Yeah. So hopefully that's been interesting. Thank you very much for listening.
Oh, Laura, if you could unmute, please. There we go. Thank you so much for a very great talk that I can't wait to listen to again, because I'm not sure my brain comprehended as much as I would like. I tried to take some notes, and the good news is we have some questions. So we're going to start here. Says, your experiment is brilliant, and I wonder if this is something similar, if this or something similar is used in training schools at the end at all, and if not, it should be. Empathy should be an essential quality of every HCP. From Louise. So I would love your thoughts, as would Louise, on is this something that you have seen used in programs, and what are your thoughts on including it?
So thanks, Louise, for watching as well. and for all of your work that you've been doing, you know, to help us as clinicians become more aware of our role and our, you know, our role perhaps in being part of the problem. So thank you very much for all of that. I think it's not something that I have seen a lot of, but I'm sure it is happening. It's something that I use with my students, and well, my students, no, students don't belong to me, they are themselves. And then you know, they're the clinicians that are about to graduate. This experiment, this idea of feeling uncomfortable and knowing what that is like, I think is, personally, I think it's a really important part of sort of developing readiness for clinical practice, because that's the reaction to that, I think, is what is, I think it's something that is part of adding to the distress and the suffering of so many people that are trying to access support and help for their symptoms. So I think you're right. I completely agree. I think we need to learn a lesson from empathy trainers that maybe are not so well included within the healthcare professional training, and I would like to see a lot more of this. And I know that so far the new graduates, or and clinicians that are the postgraduate clinicians that do this, all see the intense value of empathy training. Yeah, if you can train empathy. That's another question though, maybe. Oh, I think you're muted, Sarah.
My
millennials. When millennials try to use technology, right? We think we know, we don't know.
No, it's too much. Okay, so we're going to scroll down. So this is kind of, there is a word limitation for the comment. So this is a 3-parter.
Okay.
So great presentation. I'm a massage therapist. Is it fair to say that the session has 3 different components? So we'll start with number 1, which is the idea was, as the practitioner thinks will happen, or ideas we have to solve. Number 2 is the idea of the client brings what they think this session will do or fix. And then number 3, being what the session space brings when interaction occurs, allowing each party to acknowledge the discomfort of pain. Both parties are jumping into an ice bucket.
I mean, I think that's a nice observation, and I think if that's, you know, when I put this session together, all I wanted to achieve was an experience of discomfort, and then to bring up a conversation around how that might affect us as clinicians. So I think what you're finding from this is a sort of helpful analysis of what is perhaps going on. We do have 2 human beings with 2 different sets of meanings around, you know, firstly around pain, and then around accessing healthcare, and what is healthcare, and what does assessment and diagnosis and treatment mean, because both of us have developed this understanding separate from each other. And when we come into that clinical space, we're not we don't arrive as blank slates. We arrive with all of this meaning and all of these expectations that are based on that meaning. And what we're trying to do in this interaction is find a way to collaborate and come together in a shared space so that we can understand that. The problem is when that doesn't happen. So when that sharing or collaboration isn't facilitated, and that might be because of something, the experiences of the person with pain, which I think at this stage we can all acknowledge is very reasonable. If you're going into healthcare for pain, you know, the experience might not have been a great one, and that's on us. We need to sort of say, well, that might be something to do with the way we're behaving. So how are we behaving? How might we be facilitating that discomfort in that person that attends our clinic? And yeah, you know, when this discomfort comes up, this person doesn't fit that sort of very traditional linear biomedical model, what do I do? That, I think that's important for us to recognize and notice, because that's when we might start, you know, actually embodying some of these communication strategies that are hurting people ultimately. So I don't know if that answers your question. I did go. It let me rant, which was quite nice.
Yeah, no, I like that. I like that a lot. So this one is going to miss part of the last word, but love this experimental session. I'm pondering what a regular empathy practice would look like. Would it need to be something neutral like this, or mindfulness of any personal discomfort to keep a humble focus?
Yeah. So yeah. So when I'm bringing these, so this is how I practice. This is what I do. I think when we're in the clinical environment, one of the things that we might, because we don't know the person in front of us, because we don't share their life or their space, we don't have access to their experiences because they're private, and often they've happened before they've come into the clinic, or it might be that they're too intense for us to try and provoke them. And I think that's something that we may have been trying to do previously as clinicians, is this sort of provocation stuff. What might be a more facilitating approach is to try and create a new shared experience that you can pull clinically relevant information out of, and that we can observe and look at and think, well, does this make sense in the wider scheme? Is this something that we can problem solve, or we can approach? We can think of what reactions come up in here, because if these reactions are coming up to this discomfort, then it's likely that there's something that we're all experiencing anyway, and that the person in pain might be experiencing in their life. So maybe it's something we can bring the unseenness to a seen level and start working there. So that's how I often integrate these different types of things. But it's not possible for them to be neutral all the time. There is no such thing as a neutral experience. Everything is biased and subjective and emotional. And what I suppose what we're trying to figure out as clinicians when we're using these things is the titration of that. And that's got to be compassion focused titration. Not if I do this, is it going to be too much, or are we prepared for what might happen if we stimulate a really difficult experience? And I think that's something that the only person that knows that is the person that's coming to see you in clinic. And that's really what informed consent is about. We're going to try this thing. It might bring up something. It might bring up some pretty intense stuff. How are you feeling about that today? Do you feel like this is a good day for us to do that? And just constantly enter into that conversation with the other person. We don't know what happened that day. We don't know where they are. So the only thing we can do is try to see the unseen, and that's got to be done through language and communication, I think.
All right, so that was our last question. So thank you for fielding those. Now, the exciting news is those of you who have backstage passes, we're going to move over to the backstage discussion, and everyone else can relax. And then we have at 7:30 a.m. Pacific, the Zentangle class starting. So we're going to move out of here and then have a lovely discussion, and we'll see you all soon.